Or good evening, everyone, depending where you are. Welcome to today's session of the Global IPC webinar series. Today's topic is identification of SARS-CoV-2 infection among healthcare workers and inpatients. So we will be talking about surveillance with today's speakers and panelists. I am Katie Wilson. I'm an epidemiologist with the International Infection Control Program at the US CDC, and I'm helping to coordinate this global webinar series. A few reminders for everyone as we get started. We do have simultaneous interpretation available in Arabic, French, Portuguese, Russian, and Spanish. If you go to the bottom of your Zoom menu and click on the interpretation button, you will see all of the options. And a note is that the Arabic translation is available by selecting the German audio channel. Zoom does not currently have an option for Arabic. So if you would like to listen in Arabic, please select the German line. During today's webinar, if you have any questions about the topic or anything about IPC, please use the Q&A button at the bottom. Some of our colleagues, including me, will be helping to moderate that Q&A. If you have any questions about audio or video or any logistics, please use the chat function, and our Project Echo colleagues will be helping to moderate those questions. The session is being recorded, and your attendance is consent to be recorded. The slides from today's session and the video recording will be available after today's webinar on the Project Echo website, and will also be in the emails that are sent out every Sunday. CME, or Continuing Professional Development credits, are available for today's session, and at the end of the session there will be a link in the chat box for the survey that you can click to. And with that, I will stop talking and hand over to my colleague Matthew Westerkamp, also from the International Infection Control Program, to introduce today's topic. Over to you, Matt.
Thank you, Katie. Good day. As Katie said, my name is Matthew Westerkamp. I'm an epidemiologist and a nurse with the International Infection Control Program with the US Centers for Disease Control and Prevention. I'm really excited to be part of today's conversation and presentations. It's been a real positive experience to talk to all the professionals that you'll meet today. I'd like to introduce my co-coordinator for today's session, Alice with WHO. Alice?
Thank you, Matt, and thank you for having me. My name is Alice Unisianu, and I'm an IPC specialist with the Infection Prevention and Control Technical and Clinical Hub at WHO headquarters. And today I'd like to introduce also the panelists. And Matt, if that's okay, if I can go ahead with that introduction as well.
Yes, please.
So the panelists we have for today are...
So Alice, I think you just accidentally went on mute.
Sorry. So we have Dr. Alessandro Cassini, who is also joining us from the Infection Prevention and Control Technical and Clinical Hub at World Health Organization. We have Dr. Diamantis Plachuras with the Surveillance and Response Support Unit of the European Center for Disease Prevention and Control, Dr. Rajini Gaind, Professor and Head of Microbiology at Safdarjung Hospital in New Delhi, India, Dr. Ivan Ivanov, who is the team lead of the Occupational and Workplace Health at World Health Organization, and Dr. Rachel Smith, which is the team lead for surveillance with the International Infection Prevention and Control team at US CDC. Thank you.
Thanks, Alice. And thank you to all the panelists for joining us today. I'm going to start with my presentation. This summary presentation will be brief. Additional resources and further reading will be provided at the end of the presentation. I have nothing to disclose. My objectives for this presentation are to describe general strategies for case identification in health workers and inpatients. We will group these strategies by principal data source and the amount of effort required as passive, enhanced passive, and active strategies. A note on terminology. I'll use the term healthcare workers in a general sense to mean individuals who work or volunteer in healthcare facilities. In this sense, I'll use healthcare worker, health worker, healthcare personnel, and staff interchangeably throughout. In addition to triage and good infection prevention and control practices, the quick identification and appropriate management of suspect cases in healthcare workers and inpatients will help ensure that healthcare facilities do not act as points of COVID-19 amplification. While an issue of concern, we do not have time today to discuss asymptomatic case identification. Our focus will be on ensuring rapid identification of symptomatic staff and inpatients. During our Q&A session at the end, we may discuss asymptomatic testing some. Regardless of the case finding strategy employed, there are general best practices that will help ensure effective and efficient detection. Train and educating healthcare workers on signs and symptoms of COVID-19, highlighting recognition of cases among their patients, as well as self-recognition for themselves is valuable. Training can be enhanced through job aids and reference materials to support a high index of suspicion regarding suspect COVID-19, and resources will be available online through the links at the end of this presentation. All healthcare facilities should monitor and manage ill and exposed healthcare workers, including flexible and non-punitive sick leave policies that are consistent with local and national healthcare guidance. And finally, reporting within and between healthcare facilities and public health authorities should be established and used regularly. First, we'll discuss strategies for the identification of healthcare workers with suspect COVID-19. The objective of strategies to support identification of symptomatic or ill healthcare workers is to prevent exposure of patients and staff to symptomatic COVID-19 positive staff. Different strategies, such as routine testing of healthcare workers, would be required to identify and prevent exposure to infected individuals that do not have or do not recognize their signs and symptoms. This discussion will focus on three strategies: passive, automated and manual enhanced passive, and active strategies. Passive healthcare worker case identification involves staff assessing for fever and a defined set of symptoms compatible with COVID-19, and is probably the most common that you'll see in the field. Healthcare workers with signs and symptoms are expected to remotely report their condition to avoid exposing others, not report to their healthcare facility unless medical care is needed, and must be provided with rapid medical assessment and follow-up actions. Reporting is not enough. Actions to respond must be in place, or should be in place. General passive strategies provide a mechanism for the identification of healthcare workers at an increased likelihood of infection with minimal resource requirements and should help avoid facility exposures. Enhanced passive strategies may be achieved by establishing a reminder or prompt to healthcare workers to self-assess for signs and symptoms of COVID-19. Evidence supports the utility of simple reminders to substantially increase adherence. This strategy requires either an automated reminder system, such as mass texting services, or manual phone calls or direct messages to remind staff for self-assessment. This can be resource intensive. Active healthcare worker case identification strategies attempt to ensure healthcare workers are free of COVID-19 signs and symptoms by either in-person assessment prior to each shift or a remote system in which staff confirm that they have self-assessed for symptoms. In this system, staff report both positive and negative findings, unlike passive systems in which they only report positive findings. Considerations for active Strategies include the active monitoring of healthcare workers can be highly resource intensive, and acceptance by staff may be limited by perceptions of mistrust in their ability to report their own symptoms appropriately. Now, strategies to support the identification of inpatients with suspected COVID-19. The objective of these strategies are to identify inpatients admitted and not previously identified as suspect COVID-19 case patients. Recognition can help guide infection prevention and control to prevent nosocomial transmission. Passive strategies for inpatient identification focus on ensuring that clinicians have the latest evidence on signs and symptoms of COVID-19 in different patient populations, as well as a clear understanding of what to do if a patient is suspected of COVID-19, such as isolation precautions, PPE use, reporting and informing IPC focal people at the facility and public health authorities, and how to obtain testing. Passive strategies strive for minimal disruption of existing clinical practice and have no or minimal requirements for standardized data collection and form completion. These strategies work to support and encourage recognition and reporting by astute clinicians. Similar to enhanced passive strategies for the identification of symptomatic healthcare workers, enhanced passive strategies for inpatient case finding provide a prompt to clinicians to systematically reassess inpatients for COVID-19 compatible symptoms and support appropriate consultation and reporting. While these strategies may seem like common sense, systemization of practice can help ensure that patients are not missed as healthcare workers and clinicians become busy and rotate between units and possibly facilities. Examples of enhancements to passive strategies include including COVID-19 and sign-out change of shift reporting for all patients, requiring patient care units to provide a daily clinician-generated list of suspect cases, and specific daily requirements to clinicians to report and discuss patients with symptoms or histories suggestive of COVID-19. Finally, active strategies to support inpatient COVID-19 case finding involve the data collection and the review of patient information by groups specially responsible and trained for this role. Example of groups that might be assigned to data collection and case identification include IPC teams, representatives from the ministries of health, and teams from subnational or local public health authorities. A main criterion is that these individuals are specifically tasked for identification of COVID-19 patients outside of their normal clinical duties. I have two references that I'm providing. These are really gateways to a lot of available resources, and I encourage people that are listening to go and see what is available out there. Thank you. Now, before we move on to our speakers, we have 4 polling questions for all attendees. You will see these questions on your screen. I will read the question and allow about 30 seconds to answer. I'm going to stop sharing my screen and put up the first polling question. These polling questions are fun. Please do participate. While our population here is select and biased, the findings are far more informative if our sample is big. So, poll number 1. How is your facility working to identify healthcare workers with COVID-19? You can choose multiple. Passive strategies as described, active strategies, testing of healthcare workers not based on reporting symptoms, so that would be asymptomatic or pre-symptomatic, none, standard policy, we're just doing what we've always done, and I don't know. It's fun to watch them come in. All right, I'm going to give you a couple more seconds here and then I'll end it. We're right at about half. So I'm going to go ahead and end this and share the results. It looks like passive strategies are the most common, and that's definitely what we see in our work in the field with 53%. Active strategies second at 29%, and 18% are looking at testing of healthcare workers not reporting symptoms. So very interesting. I'm going to go to the second question. How is your facility working to identify inpatients with COVID-19? Again, you can select multiple: passive strategies, enhanced passive strategies, active, routine diagnostic testing of inpatients not exhibiting COVID-19 symptoms, and none, standard practice. And of course, I don't know. Excellent, we're almost at 200. Great, I'm gonna go ahead and end the poll here, show you the results. Again, passive strategies are the most common at 52%. That's specific work to promote the astute clinician. Enhanced passive at 26%. That's good to see. I'll be curious to learn more about the systems that are being used for that. Active strategies at 23% and 16% with the routine diagnostic testing. At your facility, if a healthcare worker stays home because they have symptoms suggestive of COVID-19, will they be paid? Yes, always. Yes, but it depends if the absence is approved, and no, they would not be paid, or I don't know. I can tell you this one is, this is good. All right, that was a fast one. I'm gonna go ahead and end. So 60% yes, always, 28% yes, but it depends on if it's approved, and no at just 4%. So that's, the message has gotten out there that how important these sick leave policies are. And our final question, under what situations would a healthcare worker be tested for COVID-19 at your facility? Again, multiple choice, routine regular testing, if exposed, if symptomatic, if a test is requested by the healthcare worker, and depends on testing availability. None if testing is currently unavailable at your facility. Everybody wants to answer this one. That's great. All right, we're at almost 300. I'm going to go ahead and end. And symptomatic healthcare workers are tested at 72%, which is great. There's exposure testing at 56%, regular or systematic testing at 11%, test requested at 17%. We see this as a big issue in some facilities. Depends on testing availability. I think that's makes a lot of sense at 20%, and none testing is currently not available at 5%. It's very good to see that number be small. So thanks for participating in those polls. It was it's interesting to see what's actually going on out there, especially as we're all sort of quarantined in our own little worlds. So now I would like to introduce our first speaker. Our first speaker today is Dr. Tochi, the Antimicrobial Resistance and Infection Prevention and Control Program Coordinator at the Nigerian Center for Disease Control. For disease control. Dr. Tochi, if you want to go ahead and share your screen, and you can go ahead and start your presentation.
Good afternoon, colleagues. Okay, Today, I'll share a Nigerian experience with monitoring and investigating COVID-19 infection in health workers. I have nothing to disclose. And my objectives are to describe the recommendations for monitoring COVID-19 infection in health workers exposed to COVID-19 in Nigeria, describe the process of investigating COVID-19 healthcare worker infection in Nigeria, and try to talk about how data from this investigation of COVID-19 in healthcare workers are used to inform our national response. So this is Nigeria. According to World Bank estimates, we're a population of 195,874 people. We have 36 states, and when we add the Federal Capital Territory, Abuja, it makes it a total of 37 states. And we have 774 local government areas. Approximately, the primary healthcare facilities in the country are around 34,700. The secondary facilities are around 5,500. And for tertiary facilities, it's about 164 facilities. We have currently about 98 COVID-19 treatment centers, but these numbers change as some states open more COVID-19 treatment centers. And well, the COVID-19 testing labs in the country now are around 32. So the numbers change by the day as more labs are optimized. So the current situation in the country, well, the situation as at the 9th of June is that all the states in the country, including the Federal Capital Territory, with the exception of one state, Cross River State, have recorded COVID-19 cases. And our case fatality rate is around 3%. Before I describe how we monitor healthcare workers that are exposed to COVID-19, I will explain that for NCDC as a public health institute, we find ourselves in this COVID response playing a dual role, the role of the Public Health Institute and providing the technical input and all that a public health institute does. And then as part of the response, the COVID-19 pandemic response, we also lead the infection prevention and control pillar. And that means that we play a dual role, and that has implications. So with respect to monitoring healthcare worker infection, what we have done as a public health institute is to come up with a guidance document that we intend that it be used by health facilities and other subnational public health authorities in the country who may be involved in the management of healthcare workers that are exposed to COVID-19 suspect or confirmed cases. And our goal is that this would be a tool for healthcare worker risk assessment. It will inform decision-making with respect to work restriction, and it will also help in monitoring to allow for early identification of healthcare workers who are at high risk of infection with COVID-19, and ultimately limit the introduction and spread of COVID-19 within health facilities by the personnel. So we largely leave this to the discretion of both the facility level and the subnational level authorities. And what this guidance basically provides is that it gives guidance on how to categorize risks, largely high risk and low risk exposure. Then it gives monitoring options, which include active monitoring, self-monitoring, and also provides some guidance on actions to take based on risk categories, and also recommendations on how to manage healthcare workers that are infected with COVID-19. And the symptoms we recommend that be monitored, and these are based on national data: fever, chills, shortness of breath, cough, sore throat, muscle aches, nausea, vomiting, and diarrhea. And the point we make here is that this isn't just done on its own. We recommend that it be done within the context of an infection prevention and control program, and also within the context of a functional occupational health program that provides support for the health workers. I'll move on now to how we're investigating cases of healthcare worker infection. And by this, I mean healthcare workers who become infected with COVID-19. How are we investigating them? So I'll start by explaining what we are objective and the purpose for which we try to investigate these people. We know that at the beginning of every outbreak, Africa, we were like a bit behind the outbreak. The pandemic got to us a couple of weeks later than other parts of the world. So we learn from others. And we do know that in this COVID-19, and indeed as other outbreaks, healthcare workers usually get infected early on in the outbreak. So we already had this in mind that we would investigate the first set of health workers who get infected in order to describe the epidemiology of COVID-19 among healthcare workers in the country, to also be able to describe the exposure characteristics and risk factors, and then use these findings to support the most appropriate infection prevention and control measures to be strengthened, both at facility, state, and country level in order to better protect our healthcare workers. And for us, this also allows timely investigation of COVID-19 and their related exposure, and helps us to inform our national public health response and policy decisions. And the target population for this healthcare worker investigation are all healthcare workers who test positive for SARS-CoV-2, regardless of symptoms. And we basically use a questionnaire that is administered to the affected health workers. Either personally, we send them the link, or we interview them by phone, or we get the infection prevention and control focal persons at the state or facility level to interview and get this questionnaire filled out. Before I move forward, I'll just quickly explain this SORMAS. SORMAS is a surveillance outbreak response management and analysis system. This is really the real-time reporting for COVID-19 cases in Nigeria, and indeed for other outbreaks in the country. So for us, this is our primary source of data for healthcare worker infection, because it provides real-time active investigation of active cases. And that is where we draw down our first data. What this basically gives us are those people, those cases, positive cases, confirmed cases in the country who identify as working in healthcare. And then when we do that, we go further to then get out their AP numbers, do the data mining, data cleaning, and then when we pull down these healthcare workers, these people who identify as healthcare worker, we then go forward to administer the healthcare worker investigation form, which is a more detailed form. And what sort of results have we been getting since this outbreak? You'll notice for the healthcare workers, this is the AP curve for those ones that identify as working in healthcare through SORMAS. And for those of them that say they had contact with probable or confirmed cases, 54%, but total for now for the country is around 987 healthcare workers through SORMAS. So for those, we have the healthcare worker investigation form fully filled out as at the time that these charts were drawn. You'll notice that majority of them are medical doctors, and most of them are within the age group of 35 to 39 years. And this age group directly mirrors what we have in the general population. But what we find very interesting and informative is that we look at the pie chart by the right, we'll notice that 40% are in case management and 37% work in epidemiology or surveillance. So this already points to the fact that those ones who are involved in contact tracing, case management, and other surveillance activities appear to be affected largely. And this has implications for policy, and this has also helped us in developing actions that they need to take to prevent this. For the type of health facilities that they work, a lot of them identify that they work in tertiary facilities, and for the wards, most of them are in the medical wards. When we looked at the IPC training, you notice that only about 20% say that they have received IPC training within the last 6 months. And if you further dig down to the person that did, or the organization that did the training, most of them identify that state did the training. But for us, an even more important result is presence of an infection prevention and control, or at least a quality assurance program in the facility. Over 40% do not have, and 32% say they're not sure. And for us, that they're not sure basically points to an inactive IPC program. So a lot of them, a high proportion, do not have an IPC program. And this is significant, given that part of our national strategy is that by the time COVID-19 outbreak is over, all health facilities in the country should have an IPC program in place. And we'll notice that when we asked about personal protective equipment use, over 56% did not use within the encounter with a COVID-19 patient. And the reason why they didn't use was that they were not aware that PPE needed to be used. And when we when you link this back to the poor level of training that they've received, that becomes even more significant. So, what are future plans towards surveillance for SARS-CoV-2 among healthcare workers? We have done this now deep dive of healthcare workers' infection, and that has informed and continued to inform the actions we'll take. But then going forward, we are planning to utilize the WHO protocol for surveillance for SARS-CoV-2, and we are now going to target healthcare workers who work in treatment centers in the country. That will be all, and thank you for listening.
Dr. Tochi, thank you so much for taking time out of your day to share the Nigerian experience with us. We've gotten to work together on a number of projects, and it's always interesting to hear the good work that's going on there. Our next speaker is Dr. Lakshmi, Professor and Head of the Department of Microbiology at the All India Institute of Medical Sciences. Dr. Lakshmi, please go ahead.
Can you see my screen?
Not yet. It's better than no.
Yes.
There you go. Yes, we can see it. Thank you, Doctor.
Thank you so much, Matt and whole team of CDC. Due to corona pandemic, when most of the services are closed, except few essential ones, hospitals are open and healthcare workers are sincerely providing their services, sacrificing their own safety and their responsibilities toward their families. However, some of the hospitals had to be shut down due to spread of infection among healthcare workers or inpatient, which can be attributed to the lack of strict hospital infection control practices or due to unavailability of the resources. Therefore, it is essential for each hospital in its individual capacity to formulate strategies for identification of SARS-CoV-2 infection among these populations. I am presenting here with my institution strategy. I have nothing to disclose To understand and implement strategies for identification of healthcare worker and suspect COVID-19, to understand and implement strategies for identification of inpatient with suspect COVID-19, and to emphasize the importance of application of strict infection control policies in the hospital. Our institute is situated in the heart of city of Jodhpur, a famous tourist destination that is rich in cultural heritage. This 8-year-old institute was established in 2012 as an autonomous institute under Government of India. Since its inception, the patient load has been steadily rising. At the very beginning of the outbreak, we had designated areas for COVID services in the emergency, OPD, and IPD block of the hospital. After declaration of COVID-19 pandemic on 11th March 2020, the facilities were clearly designated for COVID and non-COVID services. Out of 960 beds, 420 beds have been designated for COVID-19. The COVID testing was started from March 18th, that is a week after the outbreak. Within 3 months, more than 20,000 tests have been conducted. A week thereafter, the first positive case was detected in our lab and was admitted in the hospital on 24th March. On 11th May, that is nearly after 2 months of starting of testing, the first healthcare worker was detected to be positive. A known case of chronic kidney disease came to the emergency on 1st May for hemodialysis. He was screened at 2 days and did not meet the criteria for COVID testing. Subsequently, he was admitted and underwent hemodialysis thrice. He improved and was discharged on 6 May. On 8th May, underwent positive community screening and then while contact tracing, out of 28 contacts, including both primary and secondary contacts, 2 healthcare workers came out to be positive, 1 doctor and 1 nurse. These 2 were directly involved in this patient care. This set alarm bells ringing in the hospital, and entire hospital was shocked and became more vigilant for infection control practices. The healthcare workers are always at the risk of direct or indirect exposure in a hospital while performing different patient care activities like screening of cases, sample collection, testing, transportation of patient and infectious materials during management of cases and from the hospital environment. Working long hours in stressful conditions makes them vulnerable to distress, fatigue, and occupational burnout. These in turn may lead to breach in the infection control practices and subsequent infection. For the healthcare workers, the objectives are to identify and isolate the infected healthcare worker, to categorize the risk of healthcare workers exposed to COVID-19, to provide appropriate management and prevent exposure of at-risk patients and staff. The objectives for early identification in suspected inpatients are to identify and isolate the infected patient, to provide appropriate management of inpatient, and to prevent and limit transmission in healthcare setting. In our hospital, prior to posting any healthcare worker for COVID duty, the following are ensured: that they are not having uncontrolled comorbidities like diabetes, any immunocompromised state, ongoing pregnancy, any community exposure having influenza-like illness, and coming from high-risk zone. They undergo adequate training regarding occupational safety, donning and doffing of personal protective equipment, other infection control practices, and regularly updated on current guidelines. They are instructed to report of any type of accidental exposures to the concerned authority as soon as possible without getting panic. Proper care has been taken for fixation of their working hours and efforts made to maintain good mental health and counseling if necessary. They have to install Arogya Setu app and conduct a self-assessment daily and report accordingly to concerned authority, either by messaging or by telephonic conversation. Arogya Setu is a mobile app developed by National Informatics Center under Government of India. Arogya meaning cure from disease and Setu meaning bridge. So it means bridge to recovery. Using an all India database, this digital service is used for contact tracing, syndromic mapping, and self-assessment for these factors associated with COVID-19. It is a tracking app which uses the smartphone, GPS, and Bluetooth features to give an idea about the status of COVID positivity in surrounding as close as 6 feet from the users. And these are the sets of the questions for self-assessment. A board has been constituted by our director for daily screening and assessment of this exposure of healthcare workers. Any healthcare worker found to be a COVID suspect is reported to the nodal officer. In case of inpatient, the concerned clinician in charge does daily assessment for COVID and reports accordingly to the nodal officer. The nodal officer arranges for COVID testing and subsequent designation for admission or quarantine for healthcare worker and inpatients. Nodal person also report to the public health and state officials. Daily, all the healthcare workers pass through a desk where temperature, pulse rate, and oxygen saturation is being measured, and following questionnaires is being used for screening. And out of the 7, if anyone is positive, they are admitted in the suspect ward. Since the onset of the pandemic, the Government of India has created a network of COVID-19 testing laboratories throughout the country. Our institute is one of the mentors for establishing and initiating the COVID testing laboratories in the parent state, Rajasthan, and neighboring states. This is the national testing strategy in India. The point number 2, all symptomatic ILI symptoms, contact of laboratory confirmed cases. The point number 3, all symptomatic ILI symptoms, healthcare worker, frontline workers involved in containment and mitigation of COVID. And the point number 7, all hospitalized patients who develop ILI symptoms are who develop influenza-like symptoms, they are sent for testing. However, no emergency procedure is delayed for lack of the testing. After appropriate screening, the healthcare worker and inpatients are kept in suspect ward. And after getting the testing report, the COVID positives are shifted to COVID ward or ICU depending on their severity of illness. And negatives are kept in quarantine either at home or at institute designated centers. The proper infection control practices are being taken during patient transfer and inside the ward in ICU. According to the clinical condition of the healthcare worker or inpatient, the following treatment protocols are being followed at our institute. To summarize this, a chart algorithm of what we follow and should be followed for identification based on the CDC guidelines are given in the short. This is what I have said and what to be followed. That is, in cases of the healthcare worker, self-assessment is very important. In case of the hospital patients, the clinician's opinion is very important. And these, after the identification, whether these are the healthcare worker or in hospital patient, they are referred to the nodal officers, and then nodal officer in turn refer to the public health and state health. The healthcare workers are the key personnel in prevention and management of COVID-19. Appropriate training, self-assessment, daily screening for early detection, isolation, contact tracing, and proper management is essential. The strict infection control practices are mandatory to limit the transmission and spread of the infection in healthcare facility. With this, I conclude my presentation. Thank you for your patient hearing.
Thank you, Dr. Lakshmi. That was fascinating to see the very active approach that's been taken at your facility, and the description of the first case patient scene was very informative. Thank you. It's my absolute pleasure to introduce our final speaker for today, Dr. Silvia Costa, the coordinator of infection for the University of Sao Paulo Faculty of Medicine Clinics Hospital. I haven't gotten to work with Dr. Silvia previously, and I hope that you find her presentation as fascinating as I did when I first saw it. Dr. Costa, go ahead. Dr. Costa, I think you're on mute.
Good morning, good afternoon, good evening. It's a pleasure to be here and share our experience with COVID-19 in Sao Paulo. You can see my slides?
Not yet. While we have a second, I'm being asked by the translators to make sure for our panelists and speakers to make sure you're on mute if you're not speaking. The translators are getting a little feedback. Thank you. Dr. Costa, go ahead.
Yes. So the idea of this presentation is to share our experience with COVID-19 in Sao Paulo. That's one of the epicenter of the disease here in Brazil. I have no disclosure related to this presentation, and healthcare workers are at high risk of contracting the SARS-CoV-2, and healthcare facilities can amplify transmission among health workers and patients as in and out patients. So it's really key to have a strategy to prevent SARS-CoV-2 amplification in healthcare facilities. So I will share our strategy as reference SARS-CoV-2 hospital in Sao Paulo to prevent COVID-19 amplification in healthcare facilities. So my hospital is a public high complexity university hospital comprising 5 buildings with more than 2,000 beds and 22,000 health workers. And since the beginning of the pandemic, we implemented a strategy to identify SARS-CoV-2 infection among healthcare workers at Hospital das Clínicas of Faculdade de Medicina da University of São Paulo. The first strategy was to decrease exposure. So we decided to have only one building that will be dedicated to COVID-19 in our complex hospital, with dedicated health workers, and the hospital provides universal surgical mask, and hired more health workers, and also implemented continued PPE training every week. The second strategy was to rapid identification of sick symptomatic health workers, followed by working restriction until they are asymptomatic, and give units feedback, identify cluster, and provide intervention. And thirdly, strategy was to provide the serology to asymptomatic health workers, and again give units feedback, identify cluster, and provide also intervention. So I will talk a little bit more about this hospital, this building that is dedicated to COVID-19. So it's 900 beds building with around 300 intensive care units. We had in the beginning of the pandemic around 125 buildings, intensive care beds, and then we increased to 300 because of the needs of the city of São Paulo. In this building, there are 6,000 health workers dedicated to COVID-19. So since the beginning of the pandemic, we have been considered as the reference hospital to severe cases of SARS-CoV-2. And in São Paulo right now, there are 4 field stands hospital, as this one that's nearby our hospital that was built in the soccer or football stadium. So patients are transferred from this kind of hospitals to our hospital that is a high complexity hospital. This is our intensive care unit, and here is our ER unit. So since then, we have received more than 3,000 patients with respiratory symptoms. Among them, 59% were COVID-19 by real-time PCR. As you can see here in this graph, the green bars shows the number of patients with respiratory symptoms, and the orange bars shows the number of positive cases by real-time PCR for SARS-CoV-2. As you can see, this is a week report. Now we are seeing a decrease of both patients with respiratory symptoms and patients with COVID-19. This is just a screen that is in the main entrance of our hospital dedicated to COVID-19 that show up the direct update of inpatients positive for COVID-19, as you can see here. And then right now we have around 500 patients, and here how many patients are in our intensive care units and wards and ER. And we have also this strategy, that is the secondary strategy, that's try to rapid identification of SARS-CoV-2 infection among health workers, and they are advised to go if they present any respiratory symptoms to occupational health service. But just to remind them, we have in different locations warning poster as this one that has questions. Do you have any respiratory symptoms as cough, fever, and anosmia, because it's a new center related to COVID-19. And the hospital provides real-time PCR for all symptomatic health workers. And this here is saying that they should go if they have any kind of symptoms, respiratory symptoms, they have to go to the occupational health service to be tested, and then go home and call by phone their boss. So continue this, we perform the real-time PCR on the third day of onset of symptoms to improve the sensitivity of the test. And we collect the respiratory samples using this special swab, and we perform the charity protocol following the recommendation of WHO. Then the health works, they followed by work restriction until they be asymptomatic, they should stay at home. We have a weekly report, and a diary update, and also cluster identification intervention based on our numbers. I present here the numbers regarding the health works. I present the total number at our hospital that is 2002 health works, and up to now we have more than 5,000 that present respiratory symptoms. Among them, 35 had a real-time PCR positive for COVID-19, and in opposite of India, most of them are nurses, 36%, followed by 17% of medical residents. And then it was very surprising that 70% of administrative works were positive, showing probably that they acquired the virus at community level. And only 10% of physicians until now were positive. Here again is very similar to the patients graph that I present. As you can see, the green bar shows the health works that presented respiratory symptoms up to now, and the orange bars, the ones that had confirmed COVID-19, and is following the same situation. The numbers are decreasing right now. And regarding gender and age, most often the positive healthcare works were female, and age ranging from 30 to 40 years old. And what another interesting point is that when we compared the COVID-19 building, we had up to now 33% of our health works positive for COVID-19. And the opposite, the others supposed to be the COVID-19 free buildings, the other 4 buildings, they had more cases as this building with 42% of positive cases there. It's seems to me that the building that is dedicated to COVID-19 people, the health workers, they are more protected, they are following the policy regarding PPE and more than the others that's supposed to be COVID-19 free buildings. So these graphs show the same situation. Here in red is the COVID-19 building. As you can see, the line in red is now decreasing. And here, this building that's supposed to be COVID-19 free had here an outbreak, and we're performing whole genome sequencing to better understand what is going on there. So the third strategy was to provide some serology assay to have works at this COVID-19 building, that is the Central Institute at Hospital das Clínicas, Brazil. The first step was to validate the serology. So we used patients positive by PCR and as control blood donor from the last year. Then we set up a SurveyMonkey questionnaire that was offered for the health workers. We have to think about the logistics of the collection of the blood to avoid lines, and then the intervention, what we use the data. So we validate a rapid test that detects total antibody that was compared with the ELISA test, and the overall sensitivity was 17%, and increasing with time after symptoms onset over 10 days to 95%. The specificity was 100%, sorry, I spoke Portuguese. So we applied this serology, and we tested in 6,000 health works in 3 weeks from 6 a.m. to 6 p.m. And we decided to test it locally. So we had a rotation of units as ER, ID, wards, intensive care units, and we finished the baseline. And for now on, we have to test the health works every 3 weeks to end the pandemic. And regarding the SurveyMonkey questionnaire, it has 52 questions, but it will take only 5 to 10 minutes to answer it, and includes epidemiological, demographic data as age and gender, PPE, and transport. 40% of our health works tested positive using the serology. And we use different strategies to try to increase the adhesion to the questionnaire, as invitation by email, quick response, polls, and up to now, 3,000 healthcare workers answered the questionnaire. And the questionnaire is showing that 34% of healthcare that answer are nursing, 29% physicians, 3% laboratory workers, 2% physiotherapists, and 1% housekeeper. And most of the health workers that answered the questionnaire are female, 71%, and work at other hospital, 30%. And the type of transport to go to the hospital, most of the health workers use it. Metro bus correspond to 48%. And we ask about isolation at their homes, or if they move to another home, and 10% did it. And here is just the age that, as you can see, most of our health workers are young people between 20 to 30 years old. And regarding the unit that they work, 30% work at intensive care units, 80% at nursery, 7% at ER, and around 6% work at outpatient clinic. We ask about the influenza vaccine because it's important, because we can have a cross reaction with the serology, not the one that we're using, but a different one. And 91% received the vaccine this year. Regarding comorbidity, few comorbidity, the most frequent was hypertension and diabetes. We ask about smoking, only 7% of our health workers smoking. And regarding symptoms during the pandemic, 11% present fever up to now, and 26% present respiratory symptoms and were tested by PCR and were negative for COVID-19. We remind people regarding the information of serology, what is serology, the results meaning, what means positive and negative, and if you have symptoms after serology, what I have to do. So we have to go to the Occupational Health Service. And last but not least, now we are thinking about the next steps. So we are using and performing whole genome sequencing to understand the cluster based on epidemiology, what happened if there was transmission between health workers and patients, between patients and health workers, and vice versa. So we already have a couple of data, and we're going to perform serology every 2 weeks up to the end of pandemic, offered to households of relatives of health workers. And then the next step is performed together in our questionnaire questions regarding burnout, provide psychological support using a hotline. And I'd like to thank people that are involved in all this process, all the health workers that work right now at our COVID-19 building, and also all people from the laboratory that tested our health workers.
Thank you, Dr. Costa. That was, I really like the mix that we've heard today, from the national level to the facility level, and the positivity proportions that you described that's some of the first figures like that I've seen from folks in the field. I really appreciate you taking the time, and all of our speakers taking the time out of their day to present these valuable findings and strategies, and just sharing experience overall. I'd now like to turn things over to my co-moderator, Alice, for the question and answer session. Alice?
Thanks, Matt. So we received quite a lot of very interesting questions in the Q&As when people registered. And so I think we had about 50 that came through, and we tried to theme them. Some of them had similar themes that were interesting to us. So I will get right into it and address them to some of the panelists and the speakers that we previously introduced, and then offer the chance for anyone else to jump in from the panelists or speakers to answer those as well. So we'll get right into it. The first questions were around testing, screening, and serology. And one of the interesting questions that we've heard some answers on, but we'd like to give others a chance as well, was, do you recommend screening or testing of asymptomatic patients admitted for non-COVID-19 reasons. Some examples were for surgery or for birth. So I'd like to start off with offering Diamantis Plashuras the chance to answer this one. Diamantis?
Thank you, Alice. Yes, this is a very, very interesting question. And I think as for many of the policies for IPC in COVID, I think a targeted approach always needs to be taken, balancing feasibility and prevention, and especially when we have to do with testing, because we know both the issues with availability of tests that are not, is not the same everywhere. And also very important in all such policies is to know the prevalence of COVID in the community. So in places where there is community transmission, and this is of course currently true in many places around the globe, it probably makes sense to screen asymptomatic patients before elective surgery. And in this respect, I would also say that a risk assessment is an important tool to assess the risk from transmission, take into account both patient-related characteristics. For example, if there was recent contact, for example, with or recent risk for COVID, but also the type of surgery and anesthesia. For example, there are certain types of surgery that may be related to generation of aerosols. Just an example would be endoscopic sinus surgery, for example, and this may carry a much higher risk than, for example, orthopedic surgery of the lower extremity with epidural anesthesia, just giving an example. I think the same is also for situations like giving birth, and there again it may make sense to do screening, but of course we need also to take into account factors like the time it takes for between the test and getting the result, and always the laboratory capacity. Yes, thank you. I'm happy to discuss further if necessary.
Thank you so much. And so the next question, which we've also heard a little bit on, but I'd like Dr. Rachel Smith from the CDC to also comment on, is about recommending screening or regular testing for asymptomatic health workers and what type of screening this should be. I know Matt touched a little bit on the guidance they have. Rachel, if you'd like to jump in.
Yeah, thanks, Alice. So currently, we at CDC don't have any recommendation to do routine screening of asymptomatic healthcare workers for detection of COVID-19. We understand that this is something that's happening in many facilities and regions and countries around the globe. And I think that similar to what Diamantis said, I think that, there is, a lot to consider when thinking about a strategy like this, including the availability of testing, sort of whether testing is adequate for, symptomatic patients and exposed healthcare workers who may be symptomatic. And then, of course, there's issues around the test characteristics and diagnostic accuracy. And so, I think there's a lot to think about when implementing a large-scale screening program for healthcare workers, and it's not something that we've, on the U.S. CDC side, domestically, it's not something that we've been recommending or is in the near future for recommendations, is my understanding.
Thank you. Thanks so much. And then a lot of the questions we did receive were on serology, and we heard a little bit from Dr. Costa, but if we can pose the questions we received were, what are the strategies to utilize the results of serological tests in health worker case finding or screening? And then what are some of the limitations of these serology tests? So I was wondering, Dr. Costa, if you'd also like to jump in on that, and then we can open the floor to some of the other speakers.
Yes, there are a lot of serology as rapid tests available right now, and most of them were not validated. So it's really complicated to use one without clinical validation because they are preclinical validated. So our hospital is using these tests, but we tested in more than 7 different methodologies to decide which one you're supposed to use before we start to test in our health works. So be sure that you are using a good test. And the other important issue is that we are using plasma instead of the capillary, the finger blood. That's not so good. There are few studies showing that if you use just the finger blood, the sensitivity will be very, very low, about 30, lower than 50%. So be sure that you are using a good test. ELISA is supposed to be the best one, but depends on the ELISA methodology, because if it is IgA antibody can cross react with an influenza vaccine. So I think that it's a wise decision to first of all validate the test.
Okay, thank you so much. Now we'd like to open the floor to any of the other panelists or speakers if they'd also like to speak on their experiences with screening, testing, or serology.
Hello. Hello. Hello.
Yes, Doctor.
I would like to speak on the testing of the COVID-19. We know that the only RT-PCR is recommended for identification of COVID infection, but there is a lot of limitations like the infrastructure, and also it requires the expertise. So in resource limited settings, these are the limitations, and they cannot use the RT-PCR everywhere. So in those cases, we should take the priority of testing, means we should select what are the persons to be tested and what to be not. So first priority is symptomatic hospitalized patients, especially the elderly more than 65 years with underlying comorbidities, having high risk of complications, and healthcare workers. To decrease the risk of hospital-acquired infection and prevent the breakdown of hospital care delivery system. And the second priority should be the individual with mild symptoms in communities experiencing high number of COVID-19 hospitalization. So the strategies are based upon the resources available in the country and the resources available in the setting, and the choices are only either the screening and collecting the sample and sending to the hospital, and then testing can be done even in the expertise hospitals. Thank you.
Thank you so much, Dr. Lakshmi. Was there anyone else that wanted to comment on these questions? Okay.
Alice, hi, this is Diamantis again. May I add something on serology? I think in general, of course, RT-PCR and molecular testing is recommended for diagnostic purposes, and also for purposes of infection control. And serology may be useful, of course, in cases when the molecular test is negative and the clinical picture is highly suggestive of COVID. But of course, in these cases, probably the patient is not transmitting the disease probably anymore. I mean, when antibodies are present, they are present usually after the second week of illness, and are maybe related to less transmissibility, of course. But of course, we can also think of screening with serology tests that can provide more epidemiological information on the proportion, for example, of healthcare workers who have had previous COVID infection. So this is useful. And if I may add something on screening of healthcare workers, also at ECDC, we don't recommend general screening of healthcare workers. Perhaps some exceptions could be in cases of facility outbreaks, and especially in long-term care facilities where we have said that if cases of COVID appear in a healthcare facility, then probably a targeted screening of both staff and other residents there may be justified. Thank you. Over.
This is Rachel. Oh, I just was going to echo Diamantis saying that in the US CDC, we also have one of our regulatory agencies has asked that healthcare workers in nursing homes as a specific population be screened, even though they're asymptomatic. But yes, agree around the sort of general population of healthcare workers.
Right, I'd like to add information. Here at our hospital, we have been using serology as well to test patients. As he said, patients with clinical symptoms and CT that is suggestion of COVID-19 and are negative by real-time PCR. So it has been very helpful because can add information.
Thank you. Thanks so much. And some of you actually were answering the next questions I had. So maybe I'll jump to the following question after that. So we had some questions on returning to work post-infection. So maybe Diamantis, again, I can let you start off with this one. So the question was, in settings with limited testing capacity, how do you decide on the return to work for health workers?
Thank you. Question. In principle, currently at ECDC, we recommend that healthcare workers should be prioritized for testing. And currently, we recommend that at least 2 negative PCR tests at least 8 days after the symptom onset before returning to work. However, there is a caveat with this approach. So some individuals continue to have positive tests for longer time periods, and the interpretation of such results in terms of transmissibility is not yet very clear. So there is some emerging evidence that these cases are not linked to secondary transmission. So, and especially for settings with limited testing capacity, healthcare workers may return to work after 8 days from the day of onset and after resolution of fever and other symptoms. Or perhaps in cases of asymptomatic individuals 8 days after the test was taken. And this is based on increasing evidence that viral shedding and transmission are higher around the onset of symptoms, and also on the fact that the virus so far we know has not been cultured after 8 days from the onset of symptoms, especially for mild cases. Thank you. Over.
Thank you so much. You actually, again, answered the second part of my question. And actually, I was going to throw it over to Dr. Gained if she has anything she'd like to answer and add to this. Dr. Rajni Gained?
You want me to answer the same question? I didn't get your question.
Just if you had anything else to add to that.
I just wanted to, the high rate of transmission amongst the healthcare workers, we must have a strategy that how we need to understand that the disease, the transmission is less amongst the healthcare workers, or how it can be controlled. So you must have certain indicators which the institution can assess that the transmission, to indicate that the healthcare workers are appropriately protected. And in this case, you can have PPE compliance, personal protective equipment compliance, or hand hygiene compliance, or availability of stocks within the hospital that needs to be monitored.
Thank you so much, Dr. Gain. Does Dr. Smith or Matt from CDC have anything else to add?
I don't think so. I could only echo what's been said. It's definitely a hot topic, and the Dr. Diamantis I think captured it well. Any other thoughts?
Actually, it was a good loop into the next question that we had, which was going to be on what do you consider to be the 3 most important actions to prevent infection in clinical settings? And so actually, I'd like to pass this one over to Dr. Tochi, who we heard speak earlier about some of these. Dr. Tochi, please go ahead.
Okay, thank you very much. And I'll speak from our Nigerian experience and from a resource limited setting. One thing we consider very important is the presence of an infection prevention and control program. And by that we mean a program that at least targets the minimum requirements or standards for infection prevention and control, manned by a trained personnel. Even if it's at a minimum, a desk officer, somebody who then is sure that her position or her role is to take care of everything infection prevention and control in both the facility level and at state level. That is one. And then making it possible that people are able to practice those IPC things that are recommended, including the administrative things, the environmental things. And it is only after that that we even begin to prioritize personal protective equipment. As important as personal protective equipment are, we have found that if people are not able to wash their hands because there's no infrastructure for hand hygiene, if people are not able to even have the appropriate staffing levels, then fatigue and burnout will inevitably result in breaches in personal protective equipment. So for us in that order, we have prioritized, at least nationally, that within 3 to 6 months, starting from last month, that every health facility in the country should, at a minimum, have the WHO minimum requirements for infection prevention and control. Then we can then go on to continue monitoring personal protective equipment level, the use, how appropriately are they being used. And there's something else we have found that works, what we have called the Infection Prevention and Control Scorecard. And these are the weighted things that we consider that if every health facility is able to maintain themselves at green level, and this basically captured all the different things that need to be in place for infection and prevention and control, that if people, every health facility, whether it's a treatment center or whether it's an ordinary health facility that does not take care of COVID-19 patients, but would naturally see suspect COVID-19 cases, that if they're able to maintain these minimum standards and remain squarely in green, the chances that healthcare worker infection will be minimized. So that for us are the things we consider important. A program that is manned, training, guidelines to support what people are doing, then the monitoring and supportive supervision with the mindset of continuous quality improvement. These are the things we consider to be very important. Thank you.
Thank you so much, Dr. Tochi. And you mentioned all of the pieces that we would have mentioned as well. And also, I'd like to throw it over to Dr. Ivan Ivanov, who is our counterpart in the occupational health department here. And he is also working with ILO on all of the other aspects that are important in the prevention of COVID infection health workers. So Dr. Ivan, please. There you go.
Hello, everybody. Thank you very much, Alice. Thank you very much, Matthew, for this invitation. I was listening carefully your discussion about the infections and the testing and the masks and the strategies. And this is only part of the reality in the health facilities. Usually the infections are very complex. Many infections actually are acquired at the community. It is very difficult to identify where the health worker actually got the virus, whether it is from home, whether it is on the way to the workplace, whether it is at the workplace. It is also, we have seen publications about infections among healthcare workers being transmitted between the health workers themselves, because there is no physical distancing in the tea rooms, in the rest places for rest, and there is social mixing, sometimes even parties outside of the office where there is social mixing. So all these are very, very high risk situations. So WHO, we always say it is not the PPE, it is actually the hand hygiene that is the most important, respiratory hygiene, then physical distancing, at least 1 meter or more according to the regulations, but all the time, not getting close to people all the time, not staying within an arm length and talking to someone face to face. So these are very important together, of course, with the environmental controls, with the improvement of the ventilation, with the regular cleanup and disinfection, and making sure that health workers actually have access to compensation if they get sick or if they are unwell, if they cannot come to work, that they actually stay at home and are not incentivized to come to work. We see in many countries in low-income settings where health workers are paid day by day, and if they do not receive a compensation to stay home, they actually would come to the office with fever or would take paracetamol to control the fever in order to pass through the scanner if there is a thermoscanner in the office. And this is the reality. So we need this outbreak shows us that we need to care about health workers. We need to care about those who care in a complex way. Many of them also have mental anxiety disorders because they're afraid of the infections. They do not have PPE, but they do not receive also proper communication about what is the situation. And it is very important that we take measures for primary prevention of the infection. So before the infection happens, what we can do in order to reduce the likelihood of health workers to get in contact with the virus. We see now very modern technologies using robots, for example, for patient triage and walking the patient to the proper place, and the robot speaking 52 languages. So these are technologies that we see can revolutionize the world of work in the healthcare facilities. Thank you. Over.
Thank you so much, Ivan. And if Benedetta was here today, she'd be very happy that you threw in the hand hygiene there that she works tirelessly to promote here at WHO. Actually, you mentioned a few things that we've been also working on here in our program, and I'd like to just bring to the attention of everyone that we also posted our guidance, technical guidance on infection prevention and control during healthcare when novel COVID infection is suspected. And we have also posted IPC trainings, videos, and we have lots of documents online that can speak to some of these points if anyone is still looking for some guidance. And this actually brings me to my next point, that we have also recognized that WHO has been asked numerous times about the PPE shortage. And so WHO, alongside with other partners, has actually put together a procurement and algorithm to address the supply chain of PPE. So countries can now apply and request assistance with their PPE supply, and they will be considered through an algorithm that will hopefully be able to dedicate some much needed PPE to those health workers who are in short supply. I won't go too much into the WHO work, as I'm sure many of you have heard about it as well. But this brings me to my other question that we had frequently, which was on the surveillance and the available data of health worker infections. So I'm actually going to pass that over to Dr. Alessandro Cassini here on our team, who can start that off, and then maybe we'll move on to some of the others if we still have a bit of time. Alessandro?
Dr. Alessandro, I
Okay.
hear you on my end. It doesn't look like you're on mute. Make sure your microphone.
Can you hear me now?
Yes, yes.
Yeah, thank you so much. So yeah, sorry for that. Thank you very much, Alice. Thanks everyone for the opportunity to describe very briefly about the epidemiological data that we have here at WHO. So since the beginning of the epidemic that then became a pandemic, WHO has been collecting data, which is case-based data on each case that was found positive. And this is, as you know, a line listing kind of data. There was only one variable on health workers, which was health worker yes or no. And after the pandemic really started spreading more, it became pretty obvious that health workers were a major component in terms of the epidemiology of the disease and needed to be studied more. One of the first countries outside of China and neighboring countries of China where the disease was spreading was Italy. So I was during the very early phase of the epidemic, I was deployed in Italy and helped develop a national surveillance for health workers, where we were collecting data on several risks of exposure in health workers. When I say exposure, I mean those health workers that are actually caring for COVID patients. So they were, let's say, at risk of being infected. And now this, hopefully very soon, a report on this surveillance system is going to be published. Came back to Geneva, translated it to English, and made it a little bit more global. And finally, we managed to publish the protocol, the surveillance protocol for health workers that Tochi mentioned. Thank you very much, Tochi, for mentioning that earlier. And this is being implemented in a few countries, sometimes in a few facilities. It's basically a little bit of an epi deep dive into cases found among health workers, and it was developed in cooperation with our regional offices and partners like ECDC. Thanks, Diamantis, for providing all the input. And at the same time, we were working also on a research protocol, which is a case control, part of a bunch of protocols that the WHO has been working on called the Unity studies. And these are also anchored to some degree of funding, especially for the serological component. So this case control study, there's another one, which is a cohort study. These are research protocols that facilities or countries can implement, and they really target risk factors and try to identify in a more robust design the risk factors for health workers that are being infected. So this is on the WHO side, kind of work on that. So sorry to say that we don't have much data. We have a few countries that are reporting on which cases are in health workers, but any information on the exposures or the risks is very incomplete, if not absent. And actually, it's been now almost 2 months since many countries decided to report only aggregate data or reporting in a spotty way. So unfortunately, on a global perspective, the data is either incomplete or absent or of very low quality to actually make any kind of perspective in terms of health workers being infected. So thanks, Alice, for that.
Thank you so much, Alessandro. And actually, I've been told we are running a little bit out of time, so I might have to end the questions there. So thank you to everyone, all the panelists, speakers, for all of your presentations. Thank you to all of you who have posed questions and who have contributed to today's session. And I'd like to hand over next to Katie if she'd like to say some closing remarks. So thank you again, everyone, for participating, and please join us next week as well.
Yes, like Alice just said, thanks to all of our speakers and panelists today for the great presentations and great discussions during the Q&A. As a quick reminder, to receive CME credit, There are links available in the chat box that Amy from Project Echo posted that you can complete the survey and receive CME credit. And as a reminder, we continue next week, Thursday, June 18th, where we will be discussing dead body management in the context of COVID-19, protecting the living and respecting the dead. So we look forward to that discussion. And thanks again to everyone, and we will sign off. Have a good day.
Thank you.
Thank you.
Thank you. Have a nice day.